So we are recording this webinar today. So thank you all again for being here. We're really thrilled to have you all here. Again, this webinar is being co-hosted by AMFAR, the Foundation for AIDS Research, Positive Women's Network USA, and the Zero Project. And each of these organizations are going to be bringing, different perspectives and hopefully some powerful tools and useful tools for advocates to use as they're thinking about approaching the epidemic efforts. And we're going to talk about what that is in just a second. So AMFAR is one of the world's leading nonprofit organizations dedicated to the support of AIDS research, HIV prevention, treatment education, and advocacy. And over the last 3+ decades, AMFAR has invested nearly $550 million in its program. And their mission is to end the global AIDS epidemic through innovative research. Positive Women's Network, if you're not familiar with us, is the only national organization in the US led by and for women and people of trans experience living with HIV. And our mission is really to prepare and involve our communities in all of our diversity in all levels of policy and decision making. And I'm the executive director. I come to this work as a woman living with HIV. Zero Project is a national organization that centers people living with HIV leadership to end HIV criminalization, mass incarceration, racism, and social injustice by supporting inclusive PLHIV networks to improve policy outcomes, advance human rights, and promote healing justice. And so all of the websites for these organizations are here on this slide, and we'll also have them at the end in case you want to follow up with us about anything. So on today's webinar, thank you again so much for joining us. It looks like we have a robust crowd from around the country. We're also recording this, so it will be available for future use. We're going to talk just a little bit about what the federal End the Epidemic plan is so that folks have some context. And then we have some really special guests from AMFAR who are going to introduce some amazing new tools that they have been developing to support advocacy and really sort of strategic efforts in terms of getting to local planning processes that are effective. And then we'll have some time for discussion and Q&A as well as feedback. And folks can also put questions or comments into the chat box. There's also a Q&A feature on here that you can use. And then we'll go ahead and close. So that's our plan for today. So let me go ahead and introduce our presenters. Our two fabulous presenters today are Greg Millett from AMFAR, Vice President and Director of Public Policy. And Greg has been with AMFAR for a couple of years, but he has a long, illustrious history of doing lots of really amazing work, especially kind of elevating some of the statistics around how Black men who have sex with men are impacted by the epidemic in the US, and also looking at context and conditions globally. And for those who don't know, Greg is actually one of the main authors of the original National HIV/AIDS strategy written under President Obama, and worked in that office of National AIDS Policy during the Obama administration, and really has led the conversation nationally very much around addressing racial disparities and understanding what the impact of the epidemic actually is among Black gay men. So it's really an honor to have Greg on today with us talking about these tools. And we also have Austin Jones, who is a policy associate at AMFAR, where he conducts research on domestic HIV policy, including overlapping HIV, HCV, and drug use epidemics in the US, and has also developed a number of tools and databases for use. So just a little bit of background. What are we talking about when we talk about this End the Epidemic plan? This means a lot of different things to a lot of different people. So I think, most folks probably know that discourse about ending the HIV epidemic has been sort of prevalent for a while. Ever since we saw the results of HBTN 052, for example, where it really started to become clear that if, data started to show conclusively that if people living with HIV were virally suppressed, transmission was much less likely. And so once that study came out and sort of subsequent studies, there was a lot of mathematical modeling and things like that, looking at what it would look like if we achieved community level viral suppression so that it's much less likely that transmissions are actually occurring. And so we could kind of bend the curve of the epidemic. Also, over the last few years, we've seen other, prevention advances and interventions, including biomedical prevention in the form of PrEP being available. And so the idea that that the HIV epidemic is, that the end of it is achievable is really sort of a global conversation at this point. And so the HIV community and advocates in the US have been calling for a robust response that would address some of the structural issues that have created barriers to HIV prevention and care in the first place. Because I think all of us are pretty clear that actually a lot of the tools that are needed to, quote, end the epidemic are available to us. What's been missing is political will to do that. And political will to really make sure that we have a robust infrastructure of healthcare systems, delivery, non-stigmatizing and non-discriminatory environments to achieve the promise of these biomedical interventions. And so the many advocates in the HIV community, some folks who I know are on the line today, have been working on a domestic end the epidemic sort of vision and plan for a while, which culminated in a large community document that was put together and released at the end of last year in 2018. This document was about 175 pages, a big sort of comprehensive plan developed through collaboration with a lot of HIV organizations around the country and leaders around the country. That said, that was the community version of the vision. It's very broad, it's quite intersectional. It looks at a lot of different human rights issues that intersect with the epidemic. But this year, during the State of the Union address in February, the person who lives in the White House announced a plan to end the epidemic by 2030, which was quite different from the plan that advocates had put forward. And so this second plan, this plan from the federal government, is actually what we're talking about today. And so the plan from the administration was greeted with a bit of community skepticism for a variety of reasons, including the fact that the administration is actively taking steps to attack and undermine communities that are most impacted by the epidemic today, and that we have an environment, a political and cultural environment that actually seems to in many ways be going backwards in terms of creating a context where the end of the epidemic is actually achievable. So from attempts to undermine, the very infrastructure of healthcare at the federal level and at the state level, to direct targeted attacks on transgender people, including gender identity being protected as in terms of discrimination in healthcare settings, to some issues that we've been contending with a long time, such as laws that criminalize people living with HIV in more than 30 states, which have been shown to present barriers to both testing and accessing care. So obviously there were some concerns about the ability to actually achieve the end of the epidemic in this context. And so the plan that's been put forward by the federal government basically rests on 4 pillars. And these 4 pillars are not going to be a surprise probably to many folks. So it's basically diagnosis, expanding testing. Number 2 is treatment, expanding treatment so that we can get to that viral suppression, again, to with the dual goals of taking care of people living with HIV, but from a prevention perspective, the goal of really reducing onward transmissions. And then thirdly, a plan to scale up proven prevention interventions with a heavy reliance on biomedical interventions in the form of PrEP. And then the fourth pillar of the plan is an expanded surveillance system that utilizes something called molecular HIV surveillance, which we will be hosting additional webinars and having some resources on in the future. But this is basically a way of using viral genomic sequencing from people who test positive for HIV, or when we go to get a resistance test done to change our meds. Our viral genome is sequenced without us knowing. It's put into a database, and then CDC uses this de-identified data to sort of assess where there might be linked transmissions happening by comparing the genomic sequences. So these are the four pillars on which the federal plan rests. This information is from hiv.gov. And you can see that, you know, this is basically sort of an expansion of a lot of work that's already happening. It's nothing really new. It kind of is very reminiscent of the 12 cities model for folks who were around during that time, and this effort to sort of like, you know, put a lot of resources into a number of geographic areas to scale up proven interventions. What's not in here, obviously, is anything around structural interventions, like creating a better human rights context for this work to occur, or actually strengthening healthcare infrastructure, anything like that. So the geographic focus of the federal and the epidemic plan is, you know, it's focused in a number of geographic areas, 48 counties plus Washington, D.C. and San Juan, Puerto Rico, and an additional 7 states that have a high number of diagnoses in rural areas. And so the idea is basically that by targeting these areas, we're not getting to the whole epidemic, but we would be getting to about more than half of where new diagnoses occurred in the last couple of years. And so these are called geographic hotspots. So, what AMFAR is going to be presenting to us today is some tools that they have created to really support advocates in looking at the context in which some of this work is happening, so that we can be better prepared to think about what types of interventions might need to be made. All of these different jurisdictions right now that are included in the plan are going through a planning and formative process to basically figure out what their plan at the local level is going to look like. So that planning and formative time is funded. At a later time, there will be funding to actually implement the interventions. And so we're at a key moment of opportunity where some of these jurisdiction level plans can get informed. And that's why we wanted to make sure that folks had a chance to look at these tools and provide some feedback on them and ask any questions they might have. So without further ado, I'm gonna go ahead and turn it over to Greg and Austin.
Great. Well, thank you so much, Nana. This is Greg Millett. Welcome everybody to this webinar. I want to thank PWN as well as Zero Project for co-hosting this webinar with us. I'm joined here by my colleague, Austin Jones, and wanted to just give a quick background on this database that we developed that we hope is going to be useful for many people out in the field. We launched this database before USCA, and it was in anticipation of the conference. We thought that it would be helpful to provide advocates and public health officials with as much background information as possible across EHE jurisdictions. We kept hearing from people that they wanted to know more about what was happening in EHE jurisdictions. And the result is this, the AMFAR's EHE database. It's a free and interactive database that provides information on policy, services, demographic, and epidemiological indicators across EHE jurisdictions. If you wanted to know what the URL is for the database, it's ehe.amfar.org. Now, one of the main reasons that we developed this database is that the federal government will be collecting information on HIV incidence, on knowledge of serostatus, HIV diagnoses, linkage to medical care, viral suppression, and pre-exposure prophylaxis coverage. And they'll be collecting that information to help evaluate the initiative. But we also want to include those data as well as including and tracking contextual indicators across the EHE jurisdictions. We all know that context matters, and you can see that, headlined in our database right here. Like Louisiana expanding Medicaid and reporting a drop in HIV diagnoses 2 years after expansion, or Congress dropping its ban against SSPs in DC, and a subsequent drop here in Washington, DC in HIV cases among PWID. So understanding context is going to be crucial to identifying the facilitators and barriers that might impact EHE implementation in each jurisdiction. Now, there are three primary purposes for AMFAR's database. The first is to help a broad audience understand the opportunities and challenges across EHE jurisdictions. The second is to assist EHE sites to identify other jurisdictions with similar policies, services, or infectious disease contexts to share planning and intervention strategies. Now, we hear from people all the time, we're not in New York, we're not in San Francisco. What this database does is it allows people to see other localities that have similar policies and disease prevalence that they do, so that they can really plan with one another on the type of activities that they want to do as part of this effort. And then the last is to provide supplemental and complementary information to better evaluate outcomes across EHE sites. We know that all sites are not starting from point zero. They're not all starting from the same type of base as other sites. And we want to make sure that once EHE is done, that we're able to evaluate what were some of the policies or context that was in place that might have made it harder for some sites to implement it or easier for some other sites to implement it. So what you're seeing right now is the first page of the EHE database. If you keep clicking on the header, it gives you several different types of maps that are available. This one's on Medicaid expanded eligibility. We have other maps that are available if you keep on clicking on it. And as you scroll down, you can see that these are indicators that you could select for EHE. If you keep scrolling down on the first page, we just kind of give these headline information, we call them tiles, that really shows what's happening across EHE sites. So nationally, when you're looking at localities without expanded Medicaid in 2019, 14 of 50 states have not expanded Medicaid. That includes 5 of 7 of the EHE states and 18 of 50 of the local jurisdictions. We also have a tile for percent of people without health insurance. Nationally, it's about 12%. It's about 13% in the 7 included states and about 14% in the 50 local jurisdictions. We're also interested in looking at Ryan White providers, and again, nationally, about 1,000 providers, 111 or 12 of them in the 7 included states, about 500 in the 50 jurisdictions. And for FQHCs, it's somewhat similar, about 11,000 FQHCs nationally, with about 1,400 in the 7 included states and 3,000 in 50 local jurisdictions. In terms of HIV STD criminalization statutes, we know that there are 26 states that have exposure laws for HIV criminalization. But we also were interested in adding some of the STD statutes in there as well. And about 39 of the 50 states have both of these statutes on hand, 7 of the 7 included states and 42 of the 50 jurisdictions. And in terms of SSPs, there are about 330 SSPs nationally, 19 in the 7 included states, 73 in the local jurisdictions. As you keep going down, we provide infographics with some summary data on EHE sites across the nation, as well as an infographic that you can click on that gives you information on how to use the database. So going back to how we use a database, the first thing that you do is just select an indicator. Here we have many different types of indicators that you can select. But you can also select indicators from one of these tiles. So for instance, looking at percent of people without health insurance. This is the map that pops up for percent of people without health insurance. You see the national estimates, what's in the 7 included states, as well as the included counties. And what you can also see here too is that you can go back in time. We can go back to 2012, the number of people without health insurance. It was soon after the economic bust, and you could see that it was fairly high, and then going all the way up through 2017. And then the other thing that you could do as well for any of these maps is that you can quickly locate which one of these indicators are within the EHE sites and districts. So if you press this here, it just shows you the map according to those places that are part of the EHE initiative. If you click it again, it gives you the larger map. The other thing that these maps do is that if you click anywhere on the map, it actually gives you information for that county for the specific indicator. So this is health insurance for Marion County in Florida, where about 18.7% are uninsured. So we have all of that type of information within these maps. If you keep scrolling down, there's information that we give you on HIV profiles as well as insurance profiles. The first one on HIV profiles looks at all of the EHE sites by the 50 jurisdictions, and you can see that new HIV diagnoses per 100,000 are actually greater than what's taking place at the national level. That's this orange line, and then what's taking place at the 7 included states. So what we see in these 50 jurisdictions is much higher, but we also see that the numbers are declining, which we already know from CDC. And the cool thing is that you can click on any of these and just see what the numbers are for any different year for the national estimates of new HIV diagnoses per 100,000, the 7 included states, or the 50 local jurisdictions. The other things that we have on the right-hand side are new HIV diagnoses and some of the demographic data that are associated with it. And you can look at the national level, the states, or the counties. So right here is data on age at the national level. If you want to look at the EHE states, this is what happens in terms of age, with about 42% in the 25 to 34 category. Same thing with counties across EHE sites. For counties, again, it's 25 to 34, but the number is slightly lower than what we saw for the states. You see the same thing with race and ethnicity. We know that nationally, that African Americans are disproportionately affected by HIV, 45%. When we take a look at what's happening in the states, it's much higher. Among those 50 jurisdictions, it's about 64% of new HIV diagnoses among African Americans. And then when you look at counties, this is much closer to the national data of 45%. You can do the same thing looking at national, states, and counties for sex as well as transmission category. And you can do this as well for a number of people living with diagnosed HIV. So we have the new diagnoses, but we also have the prevalence estimates as well. And then of course the trend lines as well too for the prevalence estimates, where of course people living with HIV, the numbers are increasing because many of us are living with HIV because of ART. And that's definitely a good thing. And as you keep scrolling down on this page, we wanted to add some information on EHE localities at a glance. So it provides information on insurance policies and service sites, as well as context indicators. So we have information on Ryan White medical providers nationally and across the sites. We have the same thing on Planned Parenthood sites nationally in each of the 7 included states, as well as the local jurisdictions. Same thing with context in terms of unemployment rate, HIV, STD criminalization. One thing that we were very interested in was taking a look at the Latinx population, and you could see that 18% nationally, 5% in 7 included states, 31% in the 50 local jurisdictions. And then when you take a look at Latinx populations without health insurance, 21% nationally, about 30% in the 7 included states. And then the 50 local jurisdictions is similar to the national numbers. We do the same thing with syringe services programs and localities, et cetera. And then as you keep going down, if you want to drill further down into the data and take a look at these data according to some of these counties and states, we have this information here. Now for any one of these categories, these are the categories under insurance and facilities. If you just click on top of it, it absolutely sorts those data. So right now it's sorting it according to the counties in terms of alphabetical order. So these are all of the counties that are part of the EHE initiative for each one of these particular data. For Ryan White, medical providers, FQHCs, et cetera. And you can see in Alameda County, they've expanded Medicaid, 7% of people without health insurance. They have 8 Ryan White medical providers, 116 FQHCs. Unemployment in 2018 was 3%. And then the percent of people experiencing poverty in 2017 was about 11%. You can do the same thing for syringe services, as well as MAT access, medication-assisted treatment. And you can see whether or not any of these counties have a syringe exchange program, whether or not they're legal, how many programs they might have, whether or not they have providers who are licensed to administer buprenorphine, and whether or not there's any substance abuse facilities offering MAT. If you keep clicking along, we have HIV data for each one of the counties that are part of the EHE initiative again. And this is people diagnosed with HIV, people newly diagnosed with HIV, new diagnoses per 100,000, and people diagnosed with HIV per 100,000. And then, of course, you know, the context would be complete unless we also took a look at STD data. And we have data, again, according to the county level for chlamydia cases, for gonorrhea cases, as well as primary and secondary syphilis cases. So all of this information is all a part of the EHE database. But then there's more information that we have in here. We're really clear that we wanted to do more around the context of the epidemic and what's taking place in each one of these counties. So other than unemployment rate or percent of people with health insurance, we also have information on anti-discrimination policies for LGBT populations in health coverage. So this is a map that shows data across states for those states where discrimination is prohibited on the basis of sexual orientation and gender identity, where it's prohibited only for gender identity, such as in New Mexico or in Pennsylvania, or where discrimination against LGBT individuals is not prohibited. And unfortunately, that's in many states of the United States. Other indicators that we have as well is looking at HIV STD criminalization laws and to see what is the status of HIV STD criminalization laws across each one of these states. And of course, you just click on a state and find out exactly what type of statutes and criminalization is taking place. And most of this, of course, is incredibly important, especially within the context of U equals U, and data showing that once people are virally suppressed, that it's effectively impossible to transmit HIV. And we've had one case that was actually overturned earlier this year where the judge used U equals U to really nullify a prosecution against a man living with HIV. But there's clearly an awful lot of work that we need to be doing across the country in terms of HIV and STD criminalization laws. We also have information on the number of incarcerated individuals diagnosed with HIV. These are data from Bureau of Prisons and Department of Justice, and we have it from 2010 to 2015. Those when the data were available. And you could, again, click on any state and look at what the numbers were for that period of time. We also have that information in terms of the percent of the prison population diagnosed with HIV that people can take a look at. We're very interested in seeing what's happening with the Latinx population, especially with some of the policies at the administration level, and the fact that we see new increases in diagnoses, particularly among Latinx MSM in the United States. And this is really the percentage of the population that's Latinx in any different part of the country. So here in Pima County, about 35% is Latinx. Here in Marengo County, about 1.69% is Latinx in 2010. You can see how much that changes by 2018 with a greater proportion of many of these counties that are Latinx. And then of course, if you click on here just to take a look at just the EHE sites, you still see that there are many places where you see a large proportion of these counties that are Latinx communities. The next thing that we did though was to juxtapose that information with administrative arrests as well as deportations by ICE in many different areas. And then again, you could take a look at this by EHE sites. Now, one thing that you have to be careful with some of these data is that these data are based upon area of responsibility levels only. So these are data that ICE reports for a large region. So you could see that within specific states, that it doesn't matter what county it is, that you see exactly the same information. That's because all of this is reported by one regional part of ICE. But it's still important to have that information to give us a context of what's taking place within many of these places that are going to be part of the EHE initiative. And beyond deportations and arrests by ICE, we also have information on syringe exchange legality in the US and where SSPs are legal, not legal, and specific information on it once you click on this. And again, when you click and highlight, it shows you what type of information is taking place only in those areas that are part of EHE. Now, with that said, of course, we're not just interested in taking a look at context and policies. We're also very interested in taking a look at demographics as well as disease burden. So my colleague Austin is going to talk next about all of the indicators that we have in terms of disease burden as part of the EHE database.
Great. So thank you, Greg, and thanks as well to the organizers for having us. We're really excited to be showing this with everyone on the call here. So as Greg said, we built this database to talk about the policy and to talk about the context, but we know that the most powerful stories that we can tell as advocates, as policymakers, and as researchers often involve tying those to the epidemiology, to service availability, and to on-the-ground experience. So what I'm going to talk about is the next couple of sections that we have here in our database, which cover some of that epidemiology and service availability. And then I'm going to talk a little bit about how you can take some of this data with you, where the data comes from, and what we see as the next phase for the database, which we're also very eager to get input from the folks on this call about. So as Greg said, in addition to the policy and context indicators, you'll see on the list here, we have a large number of indicators about HIV epidemiology. That includes things like new diagnoses, people living with diagnosed HIV, and other indicators along the care continuum. So for example, if we go to HIV diagnoses, we can see that in 2017, there were about 40,000 diagnoses in the country overall, and about half of those were in the included counties, which again was the rationale for choosing the counties that are part of the plan. And we can see that there were about 3,000 in the 7 included states. If you compare that to 2008, you can see that the states have not changed very much in the number of diagnoses that they've had, while there's been a big decrease both nationally and among the included states. So this is one of the powerful things that the database lets you see. Further along the continuum, you can see things like linkage to care. You can see HIV viral suppression rates among diagnosed HIV. This is only available at the state level because of the way that CDC releases the data. But again, we can see there are wide disparities among locations that are included in the plan. So if we just like highlight the places that are included, we can see it ranges from about 53% in Mississippi, Missouri's a bit better, South Carolina at 60%, and states that have counties included, like Washington, have much higher viral suppression rates. Again, you can check these over time. The next set of indicators is about HCV, or hepatitis C. And we think of hepatitis C as really important because of the ways in which the hepatitis C overlaps with the HIV epidemic, and also the epidemic of drug use and overdose in the United States. So the first thing you'll notice when we look at hepatitis C cases is that we can't see any sort of county level detail on these maps, and that's because the CDC does not collect them, largely due to funding constraints. But we can still see that nationally in 2017, there were about 13.9 cases of acute hepatitis C per 100,000. And if we compare that to 2010, there's been an enormous increase. So this is due to increases in injection drug use across the United States, and specific states have seen really big increases. West Virginia is the most dramatic example, and Kentucky has also gone from 34 up to, or actually they've had a decrease this year, but West Virginia is up at 77.8. The next bin, as Greg talked about, is this wouldn't be complete if we didn't talk at all about STDs. And so we can see chlamydia diagnoses at the county level here, comparing nationally and in the states and included counties, as well as gonorrhea and syphilis at the county level. And then the last piece of this is the service indicators. So people need to go somewhere to get their care, and there are several models that have proven to be really effective in addressing both people living with HIV and people at risk of HIV. So the Ryan White providers are a proven model of care that have had really, really good outcomes. And so we can see where those are, which helps us know, as we're assessing, say, the program in Alabama, are there specific gaps in this map that it would be helpful to fill as part of the EHE initiative. There's also, and one thing that we should say is you can also zoom in anywhere on this map if you just click on a county. So it will go to the county. And I can hop back out. That's helpful for looking around within your state. There are also information here on federally qualified health centers, on Planned Parenthood affiliated facilities, which, as Nana referenced in the intro, have recently been affected by changes to the Title X program. And then we have several service indicators related to people who use drugs. One of these is facilities, which SAMHSA calls providing substance abuse facilities. And one thing that we can see from this map is that there are lots of substance abuse facilities in the country. One thing that we've added on this in this version is we have over here on the right a list of some of the services that are available at some facilities. This includes medications that have been proven to decrease mortality from opioids, as well as decrease the risk of HIV acquisition, like buprenorphine and methadone. And you can limit this map to, for example, facilities that offer at least one form of medication for an opioid use disorder. So if I click on one of these, it will cut it down, and we see that actually over half of the facilities are not offering any kind of medication-assisted treatment. We also have several other services here, like do the facilities offer HIV testing or hepatitis C testing, special programs for people who are living with HIV, do they accept Medicaid or Medicare, and what's the treatment setting? We also have some similar information for exchange programs. So there are fewer of these, and this is, we are aware, is an incomplete map. It comes from NASIN, the North American Syringe Exchange Network, and their Buyers Club. So only programs which are a part of the Buyers Club and have noted that they're okay to be listed publicly are on the map. And we know that there are gaps in it, but it's the best comprehensive source of syringe exchange programs that we can find. And again, you'll see from, thanks to NASIN and the surveys that they do, we have some information on what type of exchange is offered at the SSP. Is it needs-based? Is it a one-to-one exchange where you only get one needle for every one that you bring in, as well as some of the other services that are available. The final thing to say is that all of these maps are downloadable. So if you click on this, which I'll give it a shot, but maybe it won't work. But if you click on that, it will download exactly what you're looking at here. So that includes if you've selected one-to-one exchanges only, or whether you want to highlight the included places. If I click this map right now, it will give me a PowerPoint slide of exactly what I'm looking at here, as well as notes about what are the things that I have selected. So that's really helpful if you want to take any of this into a presentation or a planning document that you're planning to put together. We really encourage you to do that. One other way to get data, Greg talked through a lot of the data table here at the bottom, is there's a button here which says Export Select Characteristics. And what that's basically going to do is give you this table or something similar to it that has specific county level data that's relevant to the EHE plan that you can take with you. It's only 2 pages and easy to print out and see what's going on in your particular jurisdiction of interest. And as Greg said, it can help you identify other locations that look to be similar to yours. And then the final thing to talk about is, where is all this data coming from? So there's a couple of ways to answer that. So right now we're technically on the page that talks about syringe exchange programs. So if I go all the way to the bottom, there's information right here that says, what is this indicator that I'm looking at? Where does it come from? And where possible, there is a link directly to the place where we've gotten the data from. And at the very bottom, if you need the raw data for some reason, we've made that available here. And then finally, there's a more comprehensive list of this on our About page, which, in addition to information about the EHE initiative, about the HIV epidemic overall, there are a list of data sources, and this is just a comprehensive listing of all of the data we have available here on the database with that exact same information that I mentioned earlier. We also have some other resources, including some AMFAR briefs and information from others, a place to download all of the data if that's something that suits your needs, as well as contact information, which we encourage you to use. You can email us at dbinfo@amfar.org with any questions about the database. We're happy to take them on this call today, but if you find anything else that you want to talk about, we're happy to do that then also. And then the last thing to say is we see this as really our first phase of the database. And as Greg said, it was rolled out at USCA, so only a couple of weeks in the field right now. And we're taking input from everyone that we talk to about what would be helpful for you to inform your advocacy or policymaking or other needs. We have some ideas for that already. We want to add data on PrEP availability and uptake, which has been a little bit more difficult than some of the other things we've seen here to corral. We would like to add some data on transgender populations, which is difficult to get from the federal government for other reasons at this point in time. We're adding some data about homelessness, which we know is a strong contributing factor, both as a risk factor for acquiring HIV, but also for continuous viral suppression. And one thing that we're very excited about is to build some county and state-specific pages that will allow you to zoom into your particular jurisdiction and have a centralized source of that information. So with that, I'll turn it back over to Greg if he wants to add anything else, and I think we're happy to take questions.
Great, thank you, Austin. So I'm just going to mention one small thing before we can go ahead and move forward with taking questions. As Austin had mentioned earlier, we actually have some additional information here. We just pulled together maps of select characteristics across EHE sites. One of the things that we kept hearing was that people didn't know what was happening across EHE sites. They wanted to have additional information on that. And this map actually has all of the states and the counties that are part of the EHE initiative, and you can just eyeball all of this information on HIV indicators, policy and context indicators, STI indicators, and service indicators. And I think many of these are going to be incredibly important for the EHE initiative. Whether or not Medicaid expansion has taken place, we've seen that for the first time in 10 years, just this last year, there's been an uptick of people who are uninsured, and that has grave ramifications for people living with HIV, and that's something that we need to watch carefully. Number of Planned Parenthood clinics within each one of these localities. We know now with the changes that have been made to Title X that Planned Parenthood is no longer a part of the program. What does that mean for each one of these localities where Planned Parenthood may not be able to give services for PrEP, for African American women or lower income women or even young gay men? What does this mean for the trajectory that we've seen in reducing HIV diagnoses among women? For syringe exchange programs, even though we've seen some increases in legality of syringe exchange programs and even some SSPs that have been taking place in various parts of the United States, we're seeing that we're also losing the battle in some places like West Virginia or even in Indiana, where syringe services programs are now being dismantled. So we think it's really important to have some of this contextual and policy information along with the STD information and HIV information and service indicators to really bring a more holistic picture of what we might be able to expect from EHE and particular places where there needs to be more advocacy to make sure that this is rolled out correctly. And with that, I'm looking forward to taking any questions that people might have. Thank you.
Awesome. Thank you so much. What a robust array of tools and resources. That was really great. And it's very exciting to know that these tools are available both for End the Epidemic work and other kinds of advocacy that folks might be doing. So we had a couple questions come up on the chat box, and I also want to let folks know that I can unmute anybody to verbally ask questions. And if you want to be unmuted, I think you just need to raise your hand so I can see that you want to ask a verbal question, and then I will unmute you. So while folks are doing that, a couple questions that came up in the chat box. One is, what is the difference between dark blue and lighter blue on the map? I think, correct me if I'm wrong, but I think that varies from map to map. Is that correct, the color coding?
Yeah, that's right. You can see on any of the indicator pages, so for example, expansion of Medicaid eligibility, the legend does depend on what we're looking at here. So in Nebraska, we can see that they've adopted Medicaid expansion. It actually hasn't gone into effect yet. While Colorado has expanded, some of these have expanded, but with a waiver that might include things like work requirements, and the red are not expanded. So it does depend on which one you're looking at. And if at any point that's confusing on the homepage, if you just click on the map, it'll take you directly to this version, which has the legend and allows you to hover over anything that you want to see.
Okay, great. Thank you. Couple other questions in the chat box. And then again, a reminder that if folks want to ask questions verbally, just raise your hand on the Q&A panel, and I will unmute you to ask it. So there's also a question about the as of years. What does that refer to? Is it the data available, or what does that mean?
Yeah, one of the things that we were clear about is that we wanted to make sure that when we presented the data, that these are the data that are most recently available for any of these types of indicators. So we have it here with the EHE localities at a glance. We also have it in the data table that we've pulled together, that we want to make sure that we're giving the most up-to-date information that are available, so that people know what we're comparing here, that it's not all 2019 data or 2017 data. There's some data systems that are behind at the federal level, maybe as much as 2 years behind, so that people would understand what those data were.
Mm-hmm. Okay, great. And that actually is one question I have is for data that might be harder to track because it's not exactly in a database, or there might not be a database that's talking to yours. Like for example, Planned Parenthood clinics that are closing, or changes to HIV criminalization laws. How will those be updated, and like how frequently?
Sure. So it kind of depends on the indicator. It's a really good question. And it's one that we have struggled with depending on which indicator we're looking at. Some of the indicators on the site are updated by us automatically every week. So a good example of those is some of our facility data, like the syringe service programs or the facility data that SAMHSA releases. We automatically pull that every week. Some of them we have other systems in place to be notified when the most recent data comes out, and we have to do it a little bit more manually. But we're often, for policy data, relying on work that others are doing. So for HIV criminalization specifically, we rely on data from CDC and from others about what the latest policy information is. So when those are updated, then we pull that into our site. The one exception to that currently is on syringe exchange legality, which we normally rely on the Law Atlas project to do. But their latest update is from a couple years ago, so we've kind of done our best job at that. We do understand that there's new data coming soon on that, which we'll have up as soon as it goes out.
Yeah, so a lot of the data and a lot of the indicators are already updated automatically. We've actually written scripts that automatically searches through each one of these indicators to see if there's any updates, if there's a new download available. All of that happens automatically. But if there's any other information, as Austin had mentioned, that doesn't look like it's updated, please go ahead and contact us on dbinfo at amfar.org, and we can make sure that we take a look at that particular indicator and update it accordingly.
Okay, great. Thank you. A couple other questions in the chat. This is from Terrell Parker at NMAC. Will the website also be able to track which states offer sexual health education versus abstinence only?
Yeah, as we had mentioned beforehand, this is only, this is the first phase. So these are only some of the things that we thought were part of a constellation of things that we would like to get out immediately. There's certainly, other indicators that we can add to the database. So one thing we're clear about is we don't want to add too much. We don't want to overwhelm by having way too many indicators, but that's certainly something that we would be able to add, particularly if those data are available as part of a federal database. We really don't want to collect data state to state first of all, because that's just takes way too much time to do. But beyond that, sometimes you're comparing apples and oranges, depending upon how some of the states can collect their data, or even the way that they define what an education program might be. So anytime that there's sources of information that really comes from the federal government, where everything is defined the same way across states and where those data are available, we'd like to place that information in there. And more importantly, we really want to place information for indicators that are not just at the state level, but really get down to the granular level at the county level. So we're really trying to place a premium on that type of information, because that's what's going to help inform the EHE initiative.
Okay, great. Thank you. So if folks have follow-up questions, hopefully they can put them in here. There's a question about why isn't Iowa on any of the slides?
What's the point?
Iowa.
On any of the slides? Is Iowa part of it?
No, so I think the short answer there is that Iowa is not one of the 7 included states that was selected by HHS. As we can see on the map here, some of your neighbors are, but it also does not have any included counties. So it's falling a little bit outside of what HHS is calling phase 1 of their End the HIV Epidemic plan. We do have data on all of the states and all of the counties that, including places like Iowa that aren't included in this phase 1. And if you have input on how to make the data for Iowa more accessible and useful for you, I think we're very happy to get input on that. But just our phase 1 of this is meant to highlight the places that are included in the HHS phase 1 of their Ending the HIV Epidemic plan.
Right, and what Austin had mentioned, for many of the indicators, we actually have data from all across the U.S., down to the state level and the county level. So you could really, get the particular information from Iowa from just clicking on the map each time, rather than just going to the data tables. But as Austin had mentioned, when we get to phase 2, we're not just going to concentrate on pulling out data from the 57 jurisdictions. We want to make sure that people can click anywhere, whether or not they're part of phase 1 or phase 2, and to be able to download information across all of the indicators. So in other words, it's just stay tuned. But in the meantime, you can just click on the map and click on Iowa, and you'll find out information for any of the indicators, because that information is there.
Thank you so much. I know that we're almost at time. We have a couple other quick questions. So one is, have you considered including hate crimes or other indicators of race-related disparities?
Yes, we're looking at other indicators of race-related disparities. We're looking at, we were having conversations with Black AIDS Institute about possible indicators that we might want to add there for African Americans, just the way that we've been adding information for Latinx populations. For hate crimes, again, some of that depends upon where the data source is for that. I would suspect that some of that's coming from the Department of Justice, and we can go ahead and add that information that's contextual. We're going to add additional information as well for discrimination, for health insurance, particularly whether or not states have plans that are offering particular health plans for transgender employees of states, because we think that that would be another indicator as to how welcoming that environment may or may not be for a community that's at high risk for HIV. So there's other things that we're looking at. A lot of it, again, depends upon whether or not that information is available at the federal government, and as well if there's also information that we can get at the county level. Now, with some of the hate crimes information, of course, there's going to be some instances where you might have differences between what's happening at the state level and then what's happening at, say, a municipality level. So that gets a little bit difficult to really try and take a look at. So for instance, in North Carolina, there's really no hate crime legislation overall, but then of course you definitely have hate crime legislation in Charlotte, in the Triangle area and other places as well. And that's a little bit harder to depict on a map, but we're certainly open to try and figure out ways that we can go ahead and do that.
Okay, great. So, and I think we have one question from Cheryl. Can any state go ahead and implement the End the Epidemic plan? What I will say to that is, Cheryl, a lot of states and local jurisdictions are working on their own versions of End the Epidemic plans, kind of with or without the focused federal resources that are in this particular plan. And so definitely that is something that, you know, community groups can meet with their health departments about and start a conversation about and build a coalition around. This particular presentation is looking at the federal plan, which is focused on a set of specific jurisdictions and states. So not every state is included in this particular phase right now. So I guess since we only have about a minute or so left, I want to say there are lots of thank yous and compliments coming in on the chat box. I don't know if you've seen them, but Greg and Austin, I want to thank you both so much for not only this presentation and making the time to go through these resources with us, but really for this tool, which is absolutely fantastic and a lot of really good information that I know will be useful to all of us. We have recorded this webinar. We can send the recording around to everybody who's registered, and I think you have the contact information for the AMFAR database tool in order to follow up. So thank you again so much. We really appreciate everybody joining, and we will talk to you all soon.
Thank you.
Thank you.
Have a great day, everyone.